Now, we have seen several techniques, we have several principles, we have seen orientation of the approach can be a crucial thing when you have to address a pathology. When we look a little bit back what we had to learn in the field for these prolapses that we treated then with the percutaneous minimal invasive disc techniques, we had to learn in the first years that with any type of intradiscal procedure, you can only treat maybe subligamentary area problems, maybe intradiscal, but never extradiscal. So there is a clear limit that you cannot go to resolve problems with intradiscal solutions that when the problem is not in the inside area, but in the outside area. It has been then the step to the extradiscal foraminar approach. Here, the first application in the early 90s. We had to learn the structures in the foramen to respect them, but the access was quite broader for the lateral foraminal and mediolateral forms of disc herniation. So the range of reachability of structures was quite better. It was then another technique that came up. This was the interlaminar approach as presented by Rutten in the early years of this century. It has turned out to be a little bit special to the orientation of the cannulas. Normally it's a little bit the ascending, otherwise you have to correct a little bit the bone for the interlaminar approach. You have some thecal risk that you have to manage, that you cannot address everything freely, so you have to respect also the intercannular structures. The bleedings can be managed by the high-frequency machines that we have. We have also here learning curves, as we have discussed now. It is not the same for everybody to do the same when he has not the same experience. So we can resume the accessibility just anatomically. In the axial view, we have the interlaminar approach that comes from behind, may address across the channel this area from left or from right side, and the transforaminal can address the lateral foraminal up to the mediolateral and interforaminal forms. This is the axial view. In the frontal view, you have here the red fields, which is especially the interpedicular area, which is still quite difficult because you have to have then very highly ascending cannulas. The interlaminar approach is also a little bit limited in that area, so maybe for people that had not the absolute maximum in training, they may use in that area still the micro. And the transforaminal, you can expose the whole foramen, lateral foramen. It's a broad application, but also here you have the experience that you don't make a harm. So the learning curve here is also crucial to do the good things. In the sagittal view, you have here the situation that with the transfemoral endoscopic approach, you can address this part, and the interpedicular areas may be open or micro technique, still the technique, the approach of choice. When we see the actual range of percutaneous endoscopic systems available, we can say that with the descriptions that we have seen today, the interlaminar and foraminal endoscopic approaches challenges more and more the whole field of the intrachannular problems and lateral disc problems that we have to resolve. So even if we are not absolutely the golden standard, we will have an opportunity to go in this direction when we are critical with our results. On the results, we have already seen with Birkenmeyer's presentation that in the meta-analytic analysis, the long-term results are not so depending on what are you doing, because the long-term result is dependent more on the individual course of the natural disc degeneration. Also with whatever we do, with minimal, with maximal, with non-invasive, we will not influence the course of the natural history of the disc degeneration. So we have to communicate the gain in life quality that we can give to the patients due to the minimal approach. So if you see here that lines in the meta-analysis, conservative treatment, you have a long history to get to the end result, which may be not so different from the surgical one, but what happens in the 2 years up to get the final result, this makes a difference. So you see here, when you have here the endoscopic techniques, you get quicker to the nearly end result. So you this field, this field of sufferance, you can avoid. You can have earlier return to work and higher life quality. So we must communicate to the insurance companies, to the hospitals, that on a long run, the investment is in the first 2 years maybe after the problem occurs, and not the end results. They will never be able to prove, nor with micro, nor with endoscopic, that one of the system is better, because the basic problem is the disc degeneration process. So indication prevails the technique applied in the long-term results. And if you have people that are telling you they have nearly 100% success rate, they may have some rose red lenses on, because with the natural decourse, you get never more than about 80–85% long-term success rate. So after 2 years, we have the asymptotic decourse that you have always to face when you see publications that tell you they have 150% good results after 10 years. So I think this is the message I have to give you. The take-home message that I can show you: take the right technique for the result of problem you have. Then maybe do not go too invasive, do not make mountains if you can do that with a little instrument, with an endoscope, and remain as minimal as you can and respect your learning curve. Don't do things that you don't master, learn it, go to the courses to learn that, and you will be successful with a good long-term result. So the goal is what you can see below here: do the right thing done correctly. Do not do the right thing incorrectly. Do not do the wrong things incorrectly, and don't do the wrong things correctly. So I think goal for this, and be critical with yourself. Thank you, and welcome to Switzerland.
Each time
just a remark for the technique. I was asked by Frederick Jacot that people are asked to maintain the timings, but otherwise the program will crash. So I add some little minutes to the timings, and I hope that the other can do the same. Thank you.
So we're closing this seminar. We have coffee break, and please visit the exhibition, and please observe e-posters. And you come back here 11:05.